So, good evening, everyone, and thank you for joining us for the July lecture in our BSMS monthly lecture series. My name is Agatha, and I work in the outreach and admissions team at Brighton and Sussex Medical School. This is actually the final lecture in our series for this academic year, but don't worry, after taking a short break over the summer, we'll be back in the autumn for a new series. Just before we get started with tonight's talk, I want to make you aware that this lecture is being recorded. You, as members of the audience, won't be captured in the recording. It will only be myself and our speaker, and you will be sent a recording a little while after tonight's webinar once it's been edited and captioned, and the video will be uploaded to our YouTube page where you can also watch the recordings of all of our previous monthly lectures. During tonight's talk, if you have any questions which you would like to ask, you can submit them via the Q&A function. You are able to upvote questions, so if you see that someone's asked a question that you also want to ask, you can give it a thumbs up rather than asking the same question again. That just means it will be easier for us to see which questions are really popular. And we'll have some time at the end of the lecture to respond to any questions that have been submitted. So now, to introduce our speaker for tonight, we are joined by Adam Davis. Adam is a lecturer in Paramedic Science at the University of Brighton and has been in post for just over a year. Before joining the university, Adam served in the London Ambulance Service as a tactical response paramedic, a specialist role working closely with general and specialist police units. Adam is currently serving in the British Army as a reservist and is working towards the role of combat medical technician within an infantry unit. Adam has also previously worked in a university role at St George's, University of London, teaching paramedicine at both undergraduate and postgraduate levels, focusing mainly on trauma and critical care. Adam also has interests in interdisciplinary and interagency working, as well as crew resource management and mindset with a focus on performance under stress. So, Adam, thank you so much for being with us tonight, and I will hand over to you.
You're welcome. Okay, thank you, Agatha. Good afternoon or good evening, everyone. Sorry about that. It's obviously a long day for me. So we're going to get started. Let me just share my screen with you all. So hopefully now you can all see the screen, and you can see that we are going to talk about paramedics as part of the MDT. So in this instance, MDT refers to something called a multidisciplinary team. Okay, so that means that we're involving doctors and nurses, other paramedics, other specialities, GPs, occupational health, physiotherapists, the whole sort of gambit of a healthcare community. And you also need to understand that we use MDT, and there is also these things called TLAs, or three-letter acronyms, which there are many within the healthcare industry. So just get used to those if you are moving into this world. Right, so let's have a quick look then. So aims and objectives then. So what we're going to do, we're going to discuss the role of the paramedic within the MDT, have a look at some of the skill sets that paramedics have, but they are going to be very, very brief, and probably won't do them much service. Then we're going to have a look at the academic programme at Brighton, what is required to enter that program and what the program covers, and what the career pathways look like. So for those of you that don't know, paramedics are regulated healthcare professionals, and they're regulated by the HCPC, or the Healthcare Professions Council, and that's very similar to the NMC or to the GMC. So as we've mentioned, why talk about the MDT? So paramedics are part of the wide and encompassing healthcare system, and they play a vital role in patient care and treatment. Okay, and we achieve this, and I may end up using the royal we to refer to paramedics as a whole, but they achieve this in a multitude of ways. Okay, so it isn't always trauma, and in some regions it's increasingly true that the role is much more focused on primary care than it is on trauma or people getting hit by cars, etc. And you'll find that they far more focus on primary care in the community, and what you would sort of class as trying to treat people at home, and then referring or signposting them. And we'll get into that in a little bit as well. Okay, so I just want you to have a quick look at this one. So paramedics in the MDT with regards to some of the qualities that are required as a paramedic. Okay, So have a look. Generally, these are what paramedics bring to a team, but try to remember some of these as we're probably going to need these later. So that's going to be a little bit of a hint. So think about a team you are on. If you or somebody on your team has these qualities, ask yourself, what does this bring to the team? So if you have somebody who's incredibly good at solving problems, does that bring an added bonus to your team? Or are they always trying to solve a problem that actually it kind of slows it down? So we can always have two things with our qualities. We can have something that's a really positive impact on that team, and also we can have something that misplaced is not particularly great for that team either. Okay, but we're going to explore some of those in depth, and we can look at the characteristics and see how they impact on the multidisciplinary team. Okay, so we'll have a look at a scenario a little bit later on. It's a bit sort of out there, but you know, it's just a bit of fun. So just bear that in mind. Okay. My computer does not want to play ball with me tonight. Okay, so let's have a look at this one then. So where are you going to find paramedics? Okay, so you might find us mostly in the pre-hospital environment. Okay, that's our kind of natural habitat. But increasingly, you will find paramedics in the in-hospital arenas, in GP practices, and within community multidisciplinary teams. Okay, so it's not all blue lights and sirens and trauma and helicopters and all of that stuff. Of course, that does happen. That is part of the job. But that, in some people's mind, is a traditional view of the paramedic, that we would only respond to traumas or to car crashes or to incidents like that. Okay. But we do have a widening scope of practice. Okay, so if you're not really understanding the terminology of scope of practice, it literally just means what we encompass, what we are able to do within our skill sets. What are we trained to do? What are we capable to do? So that's your scope of practice, really. Now, that scope of practice isn't always fully understood necessarily within certain communities. So there were still instances where certain hospitals or maybe certain individuals were not fully aware of what paramedics were capable of, and were asking questions about what we can and cannot do. Now, that is on the decrease. That's fairly rare these days, but when I started, that was quite common, that we weren't fully understood in terms of our scope of practice. So if we look at the pre-hospital clinicians and we sort of follow through about who's doing what in that arena, then we've got these critical care paramedics. So they would have studied for a master's degree, and they would have been paramedics out on ambulances for some period of time. They would have learnt their trade very, very well. And critical care paramedics are focused towards those patients who are critically unwell. That doesn't necessarily mean that it's always trauma, although that is a big part of them. We think about things like cardiac arrests and running those really well. So if we think about their capability within something like a cardiac arrest, they're very good at looking after things like human factors. Now, human factors is an increasingly heavy part of what we do in medicine as a whole. And human factors refers to where we are within our bandwidth and what we're capable of within that kind of frame where we're under stress. So what are we able to do, or what are we able not to do? And are we able to spot that in others? Further in the pre-hospital arena, you have paramedic practitioners. Now, these practitioners are focused on sort of minor injuries, minor health, chronic conditions. Think of them more, if you are more akin to a GP, in so much as they are focused on these long-term benefits for patients, the longer-term scope, understanding chronic conditions, reviewing of medications. They are very well trained, and they will be able to look after those patients in the community, and they're able to make good referrals to make sure that that patient has a positive outcome. At the very other end of the scale, from where we find the paramedic practitioners, we'll find the helicopter emergency medical services, or HEMS. So they're the boys and girls in the helicopters flying out to those critically unwell patients. Now, dependent upon where you are in the country, is dependent upon what that system responds to, or how indeed it is modelled in terms of their deployment with regards to a doctor or a paramedic or two doctors or two paramedics or whatever it may be. Excuse me. So the helicopter is focused towards those very critically unwell patients, and they talk about bringing another level of care to that patient when they are critically unwell. If we then look outside of that, so if you think that that's kind of the traditional structure of where you will find paramedics, then let's have a look at things like expedition, remote and offshore, and then we look at things like military and repatriation teams. So if a national of a country is stranded in another place because they've become unwell on holiday, let's say, then that team will fly out and they'll repatriate that patient home to their medical system. If we look in hospital, for the most part, the focus there will be on advanced care practitioners. So these, again, are master's level practitioners. They're going to be looking after mainly patients within A&E and within resus. Again, very well trained. We'll get into a few other bits and pieces about what they are able to do. But if you think they'll be able to order x-rays and bloods and bits and pieces like that. So they can do full investigations on patients and they'll work within that multidisciplinary team there under the care of the consultant who is obviously running that A&E. If we look at the GP practices, then there is a slight variation here. Some GP practices will take those paramedics who are not quite qualified as a paramedic practitioner and they'll develop them in-house. So there's still potential there to go further in your career if you haven't done those extra bits and pieces in terms of learning. And then if you look within the community, they'll be part of that multidisciplinary team. Again, there's that incidents where they may not fully have received their paramedic practitioner training, but that community team and that trust that they're working for will develop them and move them on. Okay. So if we just have a look at examples of the MDT working and where you'll find us and how we do things, okay? So they're a liaison with that multidisciplinary team. So if we take a traditional view and look about how that patient is seen or how we can help them out, then the paramedic is a vital link between that scene of the incident and the patient journey. Okay, so let's explore that a little bit more. So with regards to the environment, okay, imagine that you work on the ambulance and you're the paramedic and you turn up at an A&E and I want you to think about two different scenarios. Okay, so there's an 82-year-old female and you report that when you get there, you say this 82-year-old female, she's fallen, she tripped over a tree root and she's fallen onto soft grass. Okay, so that's one patient or one scenario. The second scenario, even if it's the same 82-year-old female that you're thinking of in your head, she's fallen on the pavement and she's tripped on some loose paving slabs. Okay, so how would that information change your thought process regarding the injuries and the potential investigations that you may want to do for that patient? Okay, so then consider another patient in terms of being that vital link in the environment. Okay, a patient who may be suffering with some mental health conditions, okay, or they may have a physical disability that does not allow them full mobility around their home. Okay, if you attend that home and you find it maybe in disrepair, or there's not sufficient food, or their living conditions are poor due to the condition that they have limiting their ability to look after themselves. What are you able to see and articulate to the hospital so that they can receive a better idea of this patient and how to help them? So what information can you bring to them to say this patient may need a bit of extra help? Okay, so we then broach into the subject of something called safety netting and safeguarding, okay, which are vital roles of a paramedic within the community. Okay, so safety netting and safeguarding, that's where we're going to raise concerns about a situation or a person and we raise that to other authorities, most likely social services, and we can say to them, this patient is not doing well where they are. This person needs a bit of help. Maybe they need a carer to come round and help them. Maybe they need sort of things, what we call activities of daily living. And so they may even need help brushing their hair, okay? Or they may need help opening some tins of food or something in that vein, okay? So in which case, we can look at that and say, well, actually, we can help you. So we'll report that to the hospital, should they need to go. And then that hospital can double up, okay? So we will do a report and the hospital will do a report, and hopefully everything moves in the right direction and that patient gets what they need, and we've looked after them and we've made their life better, okay? So have a think about that with regards to the MDT working, okay? Right, it doesn't want to work. Right, so let's have a look through this one then. So the paramedic on scene is able to signpost and refer that patient to a variety of pathways. So we've had a little bit of a chat about that, okay? So if in that instance we went and saw that patient and everything else was okay, but we had a little bit of an inkling that maybe they wanted some help, but it's not quite A&E and it's not quite somewhere else, then we can call their GP. Okay, now this doesn't have to necessarily relate to those patients that we've just spoken about, especially the elderly female who's had a fall. She most likely will need to go to A&E, and the mental health crisis may well indeed need their team to look after them. But if it's not urgent, and we may be looking at something like that, say somebody's had a fall at home, they haven't really hurt themselves particularly badly, but you notice that the carpets aren't, stuck down very well, or there's trip hazards, or there's bits and pieces like that. You can move those things out of the way, and you can make sometimes you can make referrals to a specialist team where they've had a fall, and you can activate that team to come round, and maybe they can install grip rails around, or they can have a look at that carpet and have it relayed, and bits and pieces like that. Okay. Consider as well patients who may have diabetes, for instance, okay? So you may be able to go around, provide them with some treatment because maybe they've run out of their medication and their diabetes got a little bit out of control. You can stabilize them, you can make them comfortable, and quite is within their rights. They can say, I don't really want to go to hospital. This is a bit of a one-off. I've made a mistake. I don't really need to go. Assuming you've made your clinical assessment and you've made sure that this patient is completely safe, you can then call up their GP and say, well, can you see this person for a review, or can you get them a repeat prescription, or whatever it may be. Okay, so that's again that example of the paramedic being there, identifying the issue with this patient and being able to enact and to move the machine of healthcare in order to benefit that patient. Okay, so if that patient had called their GP, it may not have necessarily landed with the gravity that it does coming from another clinician. Okay, so let's have a look at MDT working in a slightly different angle. Okay, so paramedics and the ambulance service as a whole, on a day-to-day basis, regularly work with our emergency services counterparts. It's just part of it. So if you were to think of a car crash, then the fire service would attend, the fire and rescue service would attend. If that car needed stabilizing, or we need the airbags disabled, or we need the roof cut off the car, which is increasingly rare, or any of those bits and pieces surrounding safety or looking after the vehicles, there may be oil, or indeed there may be risk of fire. So obviously you want them there. The police will attend because if somebody's injured, then there may need to be some kind of criminal investigation that they want to look at. But also they're there for road safety, so they can shut the road and make sure that everybody working within that scene is nice and safe. Okay. At the end of this, or at the end of this presentation, there are some useful websites and some podcasts that I've just put together. I'm sure Agatha's going to be able to move that information along to you should you be interested. Okay. But if you were to look at the picture that we've got here, it's a fairly large scale incident. There seems to be vehicles and people all over the place. And there sort of seems to be a bit of cohesion around the team working. and you can see how the vehicles are placed, etc., etc. Okay, in these larger scale incidents, you do need this joint command structure. You need this single mission. You need everybody to be together, pointed in the right direction with a similar purpose, to understand what we need to achieve as the emergency services. And that's where something called JESIP and NARU come in. Okay, so there's the Joint Emergency Services Plan, okay, and NARU, the National Ambulance Resilience Unit. You'll be able to look them up later on, okay? But within that, I want you to think of some of the larger scale incidents, okay? Think of things like London Bridge, okay, or Manchester, or the attacks in Southport, okay? These are all horrific incidents that the emergency services have responded to, and they've responded to as best they can and in a fantastic manner, whereby they have literally saved lives because they've utilized the ability to have a joint command structure and to have everyone pointing in the right direction. Okay, there is one single mission, and there is one thing that we need to achieve, and that is to save as many lives as possible. And that's what they've achieved. Okay, so have a think to yourself, what other large scale incidents can you think of recently that have required that joint working, that you can see either in the photo there. So it may well be a crash on the motorway or whatever it may be. Excuse me. Or it may be some of the incidents that we've noted here. Okay, but think of the responders that are needed in these incidents. Okay, so what kind of specialist skill sets do you think they might be needed? So they need to be able to deploy and function within these environments, and that's where we go back to that human factors. That's where we go back to that element of needing bandwidth. Okay, so, and one of the biggest things, and this is not just paramedics, this is across medicine, it's across healthcare, is communication. Sometimes that gets lost in translation when we've got these big incidents. And I already started the incident with the talk with things like MDTs and things like TLAs. Okay, so this TLA bits and pieces, these 3-letter acronyms, if you don't fully understand, they cause confusion. So really what we need is plain English that everybody understands, that gets everybody on the same page. Okay, and that's true when we're dealing with very high stress events. Okay, so irregardless of where you may choose to go or whatever it is you're currently doing, think about how you communicate. Is it clear, and do people understand you? Okay, is relevant information being passed along? So in this instance, if you think about these big incidents, is the relevant information being passed along to the control, to the commanders on scene, to the other responders? And indeed, when you are out of sight and you're working as a specialist responder, you are a source of intelligence for those commanders. They can't see what you can see, so you can report back relevant information. If we were to look at the picture that we've got here, let's say, for instance, that the truck on the left-hand side that seems to be sort of slightly jackknifed, is at a 90-degree angle. Imagine that the people there stood in the high vis were not there, and people were not able to get round. But you were stood there and you were able to report that there's an injured casualty there. Now, if people can't see that, but you can, that's vital, isn't it? You've just saved somebody, you've brought care to somebody, you've raised attention to somebody. It's vital, relevant information. Okay. As such, as well, within this communication, you need to be able to work closely as a team. Okay, so that means that sometimes you're going to be working with people you have never seen before, and you'll probably never see again. But you are both there in order to save lives and to make a difference. And that's what you're going to do. You're going to be able to communicate with each other, develop a team, and move forward. So think of something like in this RTC here. If you can think of the firefighters that attend that incident, you're the paramedic, you're the healthcare professional. They may need a bit of guidance. Now, they themselves are trained to look after these victims, but they won't be as well trained. So they're doing a good job, and you just come along to say, you're doing a great job. Maybe let's think about this. Maybe let's think about that. And that's where your bandwidth comes in. Okay. Okay, so we're going to move on super quick now, and we're just going to have a quick look at the paramedic skill set. Now, I know I'm kind of flying through these bits and pieces. I'm aware of the time constraints, so this will be very much a flying visit. Okay, so within this, we'll have a look at clinical skills and the assessment techniques. Ever so slightly, we're just going to skim it just to give you an idea about diagnostics. Okay, again, that word communication, how does that work when we're looking at these things and moving that information along? And potentially we'll look at some of the treatment plans, or we'll look into things like pharmacology. Okay, so just on the right there within the picture, you can see the National Institute for Health and Care Excellence, okay? The Joint Royal Colleges, which paramedics use when they're on the ambulances, they'll use it as their guidelines. And then the Royal College of Emergency Medicine, when which you make things to like advanced care practitioners, they're going to be working from elements such as that. Okay. So just back to the slide then, we'll just have a look at things like CABCD, okay? Super easy, so it's just catastrophic hemorrhage. So is there lots of blood on, can you see it on the floor or within the spaces where you think they may bleed? Have a look at their airway when you consider their C-spine, so the back of their neck. Have a look at their breathing, their circulation, any disability. And what we mean by that is maybe they're not moving in the correct way that they may have been moving before. They were okay, and you can ask somebody around them, is this normal for them? But also we look at things like their pupils, and are they reacting appropriately? Do they have things like a neurological deficit or something along those lines? And we use something called a Glasgow Coma Scale as well, which will give us a score about how well adapted they are or are they not. And then E is examine and exposure, or just exposure, whichever kind of tool you like to use or variation on a theme thereof. So let's just have a look top to toe. What can we see? Are there any injuries? Are there any signs that might tell us that this person has a particular illness, or that they might have a particular injury, or whatever that may be? Having a look at the next one, the OPQRST, we use that about managing pain. Okay, so we're going to fly through it, but onset, okay, so when did it start? Okay, pain, so or palliative and provocative, so does anything make it worse? Does anything make it better? So that could do with their pain, or it could do with their positioning, or whatever it may be. Okay, then we talk about quality, so what sort of pain is it? Then we talk about radiation, severity, and then any kind of treatment that they may have put in. Okay. Then news 2, that's an early warning score, and that's been adapted ever so slightly to include things like pediatrics and those with a condition called COPD, but that's been adapted just for that use. And that kind of, we can put some observations in there that allows us to see if that patient's very unwell. So with conditions like sepsis, we might be able to put those markers in, and we can say, well, they've got a new score of X, Y, or Z, and that would help us to determine our course of treatment. Okay, so working alongside that, we're going to be utilising the guidelines, dependent upon where you're working and what you choose to do within the career. You may work under a variety of guidelines, or something that is trust specific, or something along those lines. But for the most part, paramedics work under JR Calc. Okay. Again, the link for that will be at the end. You won't be able to see the whole thing, but it gives you a good idea. So we're also ALS providers, so advanced life support. Okay, so that's when somebody has a cardiac arrest, we're able to provide them with some medication, some airway management and bits and pieces like that, in order to try and give them the best chance of survival. Okay, and then pharmacological intervention. So we work through something called a PGD, which is a patient group directive. So that may be that we give that drug in a specific environment, or to a specific group of patients who present a particular way, so that is kind of limited. Although that medicine could be used for other reasons, we may just use it just for one. Okay, and then you've got things where we spoke about the paramedic practitioners earlier, and they work in their GP practices. They will work as independent prescribers, so they'll be able to give medications off their own back, essentially, with their prescription pad, to be able to give that to patients and take their medications away. Okay. Okay, so let's just have a look at this one then. Okay, so again, the skill sets, we've talked about communication, but the skill sets are far reaching. they're not just what you can do physically. They're not just, can I hear a heart murmur? They're not just, can I put an ECG on? It's okay putting the ECG on, but you need to be able to interpret it and need to know what to do next. Okay. So then there's the communication skills, and there's strategies involved in your communication. Sometimes you will find people who are not necessarily pleased to see you. Now, that's nothing personal, that's situational. And you need to understand that situation and be able to react appropriately, empathetically, sympathetically to that patient, and to understand the condition and why they may not be so pleased to see you. Okay. And then we talk about leadership and autonomy. As you're registered as a paramedic, there is a lot of autonomy. Somebody has said to you, you have this skill set, you have this responsibility, please go out in the community and practice and make sure you're responsible and that you follow guidelines and you adhere to the HCPC regulations and policies. There's a lot to it. There's a big weight to it. Okay. Now, that in itself may be a pressure for some. Others may take that okay, but they may find the pressure ramps up when they attend those things like the car crash that we saw earlier, and there's lots of people and there's lots of trauma, and they may find that overwhelming and not function, whereas others will. As a team, you'll learn each other's strengths and weaknesses, and you'll learn that leadership in some cases is fluid, in that that person may get a grip on it initially, but somebody else comes in with a fresh set of eyes and they arrive a little bit later and say, hang on a minute, let's do this and do this and do this, and that may help this process along. So leadership in its way is not necessarily one person in charge. Sometimes it can be, but sometimes it can be more collegiate. It can be more of a democracy. It can be more of a, are we doing the right thing? What do the team think? Okay. And again, it's understanding that human factors. Okay. So do you understand what we mean by human factors? And can you recognize it in others? Are you able to work in a team and say, you're not doing so well, maybe you should come out? Okay. And then we talk about reflective practice and self-regulation, because you need to maintain your own continuous professional development. Okay. I'm just going to talk very quickly through the paramedic course at Brighton. So you can see up here on the screen what is required. Sorry, just give me 2 seconds. I've been talking for a little while. So I'm not gonna be too didactic. I'm not going to read that out top to bottom. You can see what that is. That is available on the website. I'm not the admissions tutor, so I'm not going to make out that I know fully exactly what's going on here, but you can see what's written up there. Okay. So let's just have a quick overview of the program itself. Okay, so it's 3 years in order for you to get your Bachelor of Science honours. Okay, so it's a split program, academic and placement learning. So placements, for example, will move to A&E. We'll go to theatres. Okay, we'll do paediatrics and maternity, and we'll also go to mental health placements. Okay, so that we have a really good understanding of that. So we are currently working towards having an elective within the third year, and hopefully students will be able to pick where they think their speciality may lay. So if we think of something like A&E, that will be far more geared within the third year for them to follow doctors and to work more on a diagnostic basis. Okay. Within that, then we're trying to figure out what is it that we need to do, what investigations do we want to order, what treatment do we want to provide for this patient, and let's have sort of team meetings. What do we want to do as a multidisciplinary team? Okay, so that might be of interest to a student who would want to go into their advanced care practice and move into something like that. Okay, and the focus obviously is different on each placement type, because A&E has a specific remit. If you go to something like cardiology, then there's a specific remit there, and that's all for different learning to be achieved. Okay, so the course is just revalidated, and with that, it's really good. It's a really good focused course that's on the profession as it is emerging currently. Okay, so this paramedics have really gained momentum in the way that they're seen within the healthcare professions, and also within our capabilities, and again within our scope of practice. So this course really reflects that, okay? It ensures, as you can see there, that paramedic is prepared for registration in independent practice, because it's a big thing, and we achieve that through putting students through different practice placements, and through different simulations as well, and through a series of lectures, okay? There's a big breadth of speciality within the paramedic team at Brighton, and that is only strengthening the program, really, because if there is somebody there with a specific direction in which they want to go, there is somebody there who's going to support them. There is somebody there that's going to be able to talk to them or say to them, these are the ins and outs of it, and maybe if you're interested in this, this is the road you need to travel. Okay, there's lots of clinical spaces there and lots of simulation. Okay, so and there's lots of interdisciplinary working, which is really, really important for paramedics, and about the profession moving forward as a whole. The reason for that, you can see about increasing fidelity, so that's making sure that the training is real, it feels comfortable, okay, and you're really learning because you're really engrossed in it. So we talk about that bandwidth is about people getting those students into that area where they start to feel their bandwidth is shrinking. They start to feel like they're under stress, and they're in a safe, controlled environment in order to feel like that. And if it feels like it's getting too much, they can just put their hand up and say, I think I need a break. And that's okay, because you're in a safe space to learn, okay? And as it says there, there's various forms of support and guidance, and that comes from very specialities within the university. So let's have a quick look at where your degree could take you. Okay, so do you choose to do that? Okay, so you can see on the outside there the areas of development, or the areas of speciality, if you like. Okay, so this is from the College of Paramedics career framework. Okay, so you can see that the progressions that can be made towards the centre, towards where you look at consultant and chief paramedic, directors, professors. Okay, as a whole, from my experience, most paramedics mix and match until they kind of find their niche, until they find the thing that they're really, really keen on and they're really good at, and they'll push through and they'll become a professor or a consultant or whatever it may be. Okay. So we're just going to run through a very quick scenario. I'm aware of the time, so I don't want to go over that. So it's just a quick scenario. Just have you think about if you were the paramedic or you were deployed in an environment that isn't traditional. Okay, so let's not think about the ambulance with its blue lights going around the city or the countryside or wherever you may end up working. Let's think more outside of the box, okay? Because you do find paramedics in all kinds of places, okay? So it's not a traditional thing, but it still requires a clinician, and think about the attributes that we highlighted earlier, okay? So it's just a bit of fun, and some paramedics actually do this for a living, okay? Although I think the roads are quite convoluted to get there, but it is a thing. Okay, so hopefully you've all read this by now. You're an expedition paramedic. One of your party members has become injured. Okay, you're required to treat and stabilize the patient in situ. So how will you get this patient to definitive care? And what we mean by definitive care is it the right appropriate hospital where they're going to reach the right level of care? Okay. So where is the best place for them to go? Okay. So hopefully you've got like another device maybe nearby. So you will need that, and you will need a map, and just have a quick little play along. Okay. So your patient, 54-year-old Fred, okay, he slipped whilst he's walking on the rocks at the beach, which is unfortunate because this looks like a lovely part of the world. He suffered a broken ankle and a wrist, and he's normally fit and well, so there's no issues with Fred. He's an experienced explorer, okay? But he tells you that he's in severe pain. As you can see from the island, there doesn't appear to be much on it, so he's probably not going to receive the care that he needs there. Have a think about how do we treat him and where can we take him, okay? So are you able to stabilize these injuries where you are? Are you able to provide him with pain relief where you are? And is it the right pain relief? Okay, does it have side effects? Let's think about things like that. Is he going to be able to fly him off of this island? Are you going to be able to take a boat? Okay, so think about those sort of bits and pieces. So here's some injuries that Fred has sustained. Okay, so on the left-hand side of your screen, you can see that he's sustained something called a Colles fracture. Okay, and some people say it's like a dinner fork upside down. Okay, so you can see where it's displaced. And on the right, you can see that he's suffered a fracture there to his ankle. Okay, so, and he's not looking in great shape. Okay, so he's probably not going to be able to walk. And if he's left-handed, he won't be doing any writing either. Okay, so your patient is located on Komodo Island. Okay, so if you've got your other device, have a look for Komodo Island. Okay, and try and find out where that is in and where it is in the world. Okay, now the challenge when we look at Komodo Island is, where is it in the world? Is there a clinic nearby that we could take Fred once we've sort of stabilized him and made him a bit better? And do we think that that clinic nearby is going to be able to provide Fred with the appropriate care that we want him to get? Now, as a caveat and a disclaimer, I picked this at random. I've never been to the Komodo Island, so if there is anybody there that knows, then that's great. There's probably a wonderful hospital there somewhere. But this is just for purely theoretical sake. Okay, so is the right hospital there? If it isn't there, then where's the nearest place that we could take him, and how would we get him there? Okay, so how are we going to move our patient? Okay, so we could take one of these extremely large helicopters. We could take one of the boats. Okay, what's your mode of transport? And if you think about that mode of transport, how comfortable or uncomfortable will it be for Fred when he's popping along to the hospital? Okay, are you going to be able to look after Fred whilst he's en route to this definitive care? Okay, you've got the rest of your expedition to think of, bits and pieces like that. Okay, this definitive care, where are we going to find it? Now, if we kind of look at Komodo in the world, there's some places around it that seem, oh, we could take him there, or we could take him there. The question is, if we are going to fly him, how would we achieve that? Where's the nearest landing strip, and what sort of team does he need to come and get him? So we spoke about repatriation earlier. So there's potential for air ambulances, because you would have to call his company, his insurance company, or whomever it is that looks after him, and say, Fred's had a fall, can somebody come and help? And they may arrange for the air ambulance to come, and they may arrange for the doctor to come and pick him up and fly him somewhere else, and they can look after him whilst you can go back to your expedition and look after the rest of the team. Okay, so there's lots to consider there. Okay, it's a slightly extreme scenario. It's a little bit off the cuff, but it's just a bit of fun, really. Okay, so in principle, though, the work remains the same. You need to treat the patient appropriately, whichever way you choose to do that. I understand that that's not really something we're going to get into here, but it's a consideration. What would we do as that pre-hospital care specialist in that environment? How would we treat that person appropriately? Can we take them to the most appropriate destination for their injury? And that's true even in day-to-day ambulance work. If you consider that you're working in London and somebody has a heart attack, then you would take them to a specialist hospital so that those doctors can look after them appropriately within that facility. And you wouldn't just go to the nearest hospital, okay, unless there was some other issue. And you're going to work with that multidisciplinary team, because you say you're going to call the insurance company who've got their nurses and their doctors. You call the air ambulance team and you say, look, can you come and get Fred? There's still that multidisciplinary team that relying on you as a clinician to communicate effectively and to provide the right information at the right time, okay? Clear, concise information, okay? And hopefully we all ride off into the sunset, happy, healthy, and having made a difference in somebody's life, okay? There's some of the further reading there. So we've got some of the websites and the podcasts that you can flick through. So we've highlighted those bits and pieces. At the very bottom there, you can see I've just put in some links. They're Apple Podcasts, but you can get them anywhere, you know, even if you've got Spotify or whatever. So the Resus Room, the Royal College of Emergency Medicine Learning, and Geeky Medics, which is always a really good resource and allows people to have some really good access to medicine. Okay. And that's it from me. So thank you very much for your time. Thank you for listening. And if you do have any questions, I'd be more than happy to answer them.
Thank you so much, Adam. That was a really interesting talk. I really enjoyed it, and I learned a lot. Like I kind of like you were saying, I think I had really been thinking about paramedics as, like you said, all trauma and car crashes. So it was really great to kind of learn a bit more about that scope of practice, to understand that safe netting, safeguarding kind of community care that you were talking about. And I think it was really interesting also to hear about, how kind of uniquely the paramedic is positioned within to do that multidisciplinary working, right? Like with people in the hospital and the GPs, but also those other emergency services who aren't kind of clinicians as well. So thank you so much for that.
You're
We've got
more than welcome.
some questions in the chat as well. I think some
Yeah.
people are potentially some budding paramedics.
Okay.
Someone's asked for a bit of advice about maybe what steps they should take or things they should look into to decide whether being a paramedic is a career for them.
Yeah, so that's always an interesting one and a tricky one to answer in some respects, because it really does depend on what that individual wants from the profession themselves. But you can always email your local ambulance trust, and you can ask if you can have a ride out with them, and 9 times out of 10 they'll be more than happy to do that. There are obviously sort of the go along and meet your crew days. Sometimes they have like local fairs or bits and pieces like that where a local trust will turn up. There's voluntary roles, so always think about things like St John's or the Red Cross, being able to volunteer for those careers as well. And then obviously, if you're more leaning towards the military, or you're more leaning towards that side of things, then there's other ways of sort of getting in touch should you be old enough to be looking to join the reserves. But they are always happy to talk to people about that sort of service and what's required of them. So the best answer is just kind of reach out to whomever it is that you think that you may want to get involved with, email them, and just sort of state your position, state where you are, what you'd like to do, and what you'd like to achieve. And 9 times out of 10, if they can't help you, or they say, "Oh, I'm sorry, we can't do that," they will point you in the direction of somebody that can.
Brilliant. Thank you. Really good advice there. Um, we've got some other questions kind of about training.
Yeah.
Someone says, can you become a paramedic straight out of medical school, or would you need to do a postgraduate degree to train separately as a paramedic?
So that's an interesting one. So if you've graduated as a doctor, you wouldn't need to do paramedic training. But if you were interested in becoming a pre-hospital doctor, then there's a different pathway for people to follow. Now, let me think. I believe it's at St Mary's. Now, I don't want to steal people's thunder because this is about Brighton and Sussex. So, but I believe it's there, and they do a program for pre-hospital doctors. So I think that's a year. And some of the doctors that I worked with had done that pathway. So they did 2 years as an undergraduate at med school. They interrupted and did a year's BSc for pre-hospital clinician, and then they carried on their another 3 years for medicine. So that just gives them that understanding of the pre-hospital environment. But at the end of the day, if you've graduated as a doctor, you're a clinician. You don't necessarily need to understand the pre-hospital guidelines, etc. But what you would need to understand is the pre-hospital environment and how to work in it and to navigate your way around it. And that is a very different thing to working in A&E. So if you graduate as a doctor, you can then look at schemes like Basics, and they do some pre-hospital care work. I can provide you with a link afterwards, and you can send it on if you wish.
Thanks, Adam. Yeah, I'll make sure I get all those links that you've put together, and anything else we want to add, I'll get that out too. Thank you. That's really helpful. I guess
No worries.
it's good to kind of mention to the audience as well. It's like, so if you know you want to be a paramedic rather than a doctor, you can do the paramedic course, right? Like at
Yeah,
Brighton or other providers, which is like a 3 year course. So
yeah.
it's kind of there are different routes of training. So you don't need to do both, and you wouldn't do both. You'd kind of choose one or the other, right?
Yeah, so I think from my experience, what we've had is people that have graduated as paramedics. They've gone out and they've done their time out on the ambulances or within their communities or whatever it is that they need to do, and then they've taken or they've sat like GAMSAT exams and things like that, and they've
Mm.
gone back into learning, and then they've become doctors themselves. And the anaesthetist that trained me was Canadian, and he had graduated as a paramedic first and then become a doctor. So it's not an uncommon road in any way, shape, or form, and there's quite a lot of modules that are lining up that do kind of match and are able to kind of give paramedics a little bit more when they're looking at applying to med school. Conversely, we are looking to do more and more with the med school so that we can kind of embed that pre-hospital element into undergraduate medicine. So yeah.
Yeah, absolutely. I mean, I think that's really important. Um, Great. So kind of, yeah. So options for people depending on kind of, even if you start maybe down one path, there's always options to kind of take it into different places.
Yeah, 100%. I think what we found is that there is a bit of it in at the deep end with regards to paramedics, because you're out on the ambulance when you do your placements and you're out seeing patients, and you have to talk to them and you have to develop a bedside manner and you have to understand about your assessments and your tools to communicate and have your communication strategies. Whereas that's a little bit slower within the medicine element. So
Mm.
you may find that your if you choose to do the paramedic element first and then choose medicine, you may find that you get along a little bit easier because you've got that prior knowledge
Mm.
within that arena. Anyway, let's put it that way.
Yeah, absolutely. Thank you. Um,
So,
I've got another question. Someone's asked about how being a paramedic in the army differs
mhm.
from kind of being a paramedic in sort of a civilian life. Do you
Okay.
get more experience in treating certain injuries or wounds?
Uh, so that again, it's a tricky one to answer because
Mm.
if you were deployed to somewhere where there was um, lots of trauma, so a conflict or indeed a humanitarian crisis, because they do get deployed to bits and pieces like that, such as earthquakes, etc. Then you may well experience, that kind of trauma uplift, if you like, or that focused trauma treatment. However, if you are not deployed into that environment and you are working sort of day to day, you may find that you're managing a med clinic or you're working within a med clinic, so that you're looking after the soldiers and their families. And that's, if you join the Air Force or if you join the Army, that's kind of how these things break down. Um, what you'll find is that as a paramedic within the military, um, your treatment options are slightly different, your guidelines are slightly different, and you may be able to do procedures within the military that you would not be able to do in civilian life. Or may be able to give medicines within the military that you would not do in civilian life. With that said, conversely, your exposure within civilian paramedicine may be slightly higher on a day-to-day basis. So if you think of a humanitarian crisis, that's a very large amount of patients within a very semi-permissive environment, because you're working maybe around sort of structures that are not sound or whatever that may be. And so you do get like a large amount of patients all at one time, and that's for you to manage um, sort of there and then, along with your team and everybody else. Versus what you could sort of class as a slow drip of
Mm.
patients within. civilian paramedicine. So I think in terms of your scope of practice and your registration, you're still registered. You're still registered under the HCPC, but there may be a slight difference in your skill sets and within your scope of practice, and who you work with and where you work. They're probably the big differences. But there is a lot online. So, the British Army website with regards to the reserves, they'll be able to provide lots of information about what's expected as a combat medical technician, and they'll give you the different ideas of the different levels. And the same with the Air Force, or if you wish, there's the Navy, although I don't think the Navy employ paramedics, but I'm happy to be wrong. I don't know, so I wouldn't want to comment. Whereas obviously within the civilian environment, there's still big branches that you can go into. So things like the hazardous areas response team, who are like they go off into basically what their name says, any areas that are hazardous that may be. We talked about that humanitarian crisis. They may go like near like buildings that have suffered fire damage, and they'll go in breathing apparatus to go and get people and bring them out. They may go into chemical incidents, things like that, in order to try and save lives where maybe traditional paramedics would not go. So there's still branches within civilian paramedicine where people can experience that in different ways. So hopefully that's answered the question.
Yeah, I think that was really insightful. Thank you. And I think a really interesting question, and something that people often want to hear about, working in these different contexts that might be kind of less, I don't know, not I don't know if traditional is the right word, but different contexts that they might not be as familiar with. So thank you. That was really insightful. I'm conscious of time. I don't know if you need to run off anywhere, Adam, but maybe we could do like one more question if you have time.
Yeah, of course. No, I've got loads of time. Yeah, so I've set some time aside for this. So if you want a few more, I'm happy to do them.
Oh, thank you. Really appreciate that. It's just there's some great questions. People seem to like have been really interested, which is brilliant to see. Um, Someone's asked, obviously there are quite a few challenges to being a paramedic. They've kind of talked about things like pressure on staff, the pay not being so good, like late shifts, and sometimes maybe facing abuse. Like you were saying, people might not always be happy to see you when you turn up. Do you have any advice for kind of coping with some of the downsides of the role?
So the best thing for me is working as a tactical response paramedic was that I worked within a team, and my saving grace was my team,
Mm.
because we shared everything, literally. So we would be able to get back on station, but the oncoming teams would look after you as well if you was on a late job, and maybe don't forget things like you're still driving around in a car, so you're still like subject to flat tires and stuff like that. So you still might be just sat there waiting for somebody to come out and rescue you. And sometimes that's your colleagues, because they'll come and sit in your car and you can go home and do bits and pieces like that. I'm very fortunate. My wife is a nurse, so I'm able to have a chat with her, and she understands.
Mm.
And it's about healthy coping mechanisms, really.
Mm.
Making sure you run or go to the gym, or talk with your friends. And I think that having that team and that camaraderie is really the thing that helps you through. In terms of things like abuse that you may face, or whatever that may be, I think it comes with time that you need to understand the context of it. 9 times out of
Mm.
10, it really isn't personal. It can't be, because they've never met you before. So how could they possibly make it personal? So it's just about understanding the context. What is this person suffering with? Like, think of the bigger picture. They're not angry at you, and you've got to remember that you arrive in a uniform and in a car or an ambulance with blue lights on it. And some people don't like blue lights, irregardless of what the service is. And they want to vent at you because maybe you represent something. That's the way it is. And some people are unwell. There's a lot of mental health issues, and they're not there to fight you. They are unwell, and we need to take that into consideration, and we need to treat them appropriately. So I think it's about having context and awareness of what's going on in your situation, and not necessarily, or and not reacting to what's in front of you immediately, and having faith in your colleagues. They will help you. So that's the best thing for me.
Yeah, thank you. That was a really, yeah, I think a really nice answer and like very reflective. So thank you for that. I guess as like a final question to leave it on like a really like hopefully like a positive note. I guess
Sure.
what for you, Adam, is like your favorite thing about your job, or like the most rewarding aspect of your job, would you say?
Well, it's multifaceted, isn't it? In one day you could go to somebody who suffered a cardiac arrest, and you could do what you need to do, and you can get them back and reunite them with their family, and
Mm.
you know you've made a difference, not just in their life but to their whole family's life. You can finish that job and go and deliver a baby, and you can finish that job and go and be involved in some kind of you know multifaceted interagency operation that is feels like you're in a movie. And sometimes you have to pinch yourself because you think, well, am I really doing this? Is this really what I get to do? Somebody's literally paying me to do this. And I don't think there's any one thing that you could say is fantastic about it, because the fantastic thing about it is the variety, is that you get to do
Mm.
so many different things in one day. Um, yeah, that's what I would say.
Oh, amazing. Yeah, I think this whole talk's been really inspiring as well as informative, Adam. So just thank you so much again for coming and speaking to us all this evening. I really enjoyed it, and on behalf of the audience who, can't verbally say thank you, I just want to say thank you from everyone again. And I guess I also want to say thank you to the audience. Thank you everyone for joining us this evening. As I said, it's the last one for this academic year, but I hope to see you all back in the autumn. I'll email you after this event to send on those links that Adam's put together for us, and then I'll be in touch with you as well about upcoming lectures from kind of October time. So thank you, everyone. Thanks again, Adam. Have a lovely rest of your evening, everyone. See you soon.
Thank you. All right. Bye bye.
Bye.